So next, I'd like to invite Max Butler up to talk about Mendelian randomization analysis of metabolic determinants in Dupuytrens.
All right, apologies for that. So my name is Max Butler. I'm going to be talking about using Mendelian randomization to look at metabolic determinants of Dupuytren's disease. This was done with Professor Dominic Furness, his group at the University of Oxford. So why should we care about metabolism in Dupuytren's disease? We know that there is a clear association between different forms of metabolic dysregulation and Dupuytren's disease. However, our understanding of a causal role of specific metabolic variables here is limited. New evidence could help us identify modifiable risk factors and future targets for pharmacotherapy. So what do we already know? There's the well-known obesity paradox, where the marked protective effect of raised BMI seen in observational studies with a causal role seen in a previous Mendelian randomization study done by our group. Conversely, key metabolic risk factors include dyslipidemia, such as raised cholesterol and triglycerides, and impaired glucose handling, with hypertension, some association in some studies. Almost all of this data that we have, or this understanding, is from observational studies. As we know, observational studies can only show association, not causation. To demonstrate causation, we need to randomize an exposure, which is classically done in a randomized controlled trial. But metabolic variables, such as raised BMI, are unethical and impractical to implement in a RCT setting. What we can do is leverage population-level genetic data to mimic this study design, and this is the role of Mendelian randomization. To explain Mendelian randomization, I will take obesity as an example of an exposure. There are many genetic studies of obesity, with 800 key variants associated with raised BMI that have been identified. If you carry more of these variants, you will have a higher BMI than if you have fewer. And we can think of this raised BMI as genetically programmed. The beauty is that this genetically programmed BMI is randomly distributed throughout the population. Random allocation of chromosomes in meiosis means genetic material from our parents is randomly allocated at conception. This occurs irrespective of confounding variables and therefore mimics the randomization of an RCT. With this knowledge, we can then ask, do people with more of these 800 genetic variants that lead to a higher BMI, will more of these go on to develop Dupuytren's in greater numbers than others? For each exposure, we've selected the largest available European population GWAS, and for the outcome of Dupuytren's, we used the largest Dupuytren's GWAS to date, published last year. As a proxy for the development of Dupuytren's, we can look at whether each of the 807 BMI-related genetic variants is associated with an increased risk of developing Dupuytren's. We can do this for each of the exposures. To do so, we performed two-sample Mendelian randomization in R and also multivariable Mendelian randomization. To check that the exposure is leading to Dupuytren's rather than the reverse, we use techniques called weighted median and MR-EGA tests, which assess for directionality. So the results. First, for adiposity, the findings are consistent with previous results, where one standard deviation increase in BMI, which would be equivalent to, say, a BMI increase from 25 to 30, lowers the risk of Dupuytren's by roughly 25%. This remains significant when adjusted for waist-to-hip ratio, but not waist circumference. One standard deviation increase in waist-to-hip ratio alone cuts risk by around 19%. However, this is abolished when adjusted for BMI. Subcutaneous abdominal fat is protective, but not visceral or gluteofemoral fat. Looking at lipids, a rise in HDL, one standard deviation, increases risk by around 20%. And this is mirrored in apolipoprotein A1, which is the key constituent protein in HDL. Conversely, LDL, triglycerides, and apolipoprotein B do not show any impact. Raw waist circumference tends to be protective. However, waist circumference adjusted for BMI shows no impact. This suggests that waist circumference only matters insofar as it tracks overall adiposity. Looking at glucose and glucose handling, type 2 diabetes and fasting glucose, we can see causal risk factors. Conversely, looking at blood pressure, these traits have no causal impact on the development of Dupuytren's disease. So the key conclusions are that, as we've seen in previous observational and Mendelian randomization studies, BMI is causally protective. Interestingly, fat distribution may be a factor, with the protective effect of BMI abolished when adjusted for waist circumference, but not waist-to-hip ratio. Subcutaneous fat is protective, but not gluteofemoral or visceral fat, with gluteofemoral generally being seen as metabolically positive, whereas visceral fat metabolically negative, whereas subcutaneous fat typically metabolically neutral. Type 2 diabetes, as previously seen, appears to be a causal risk factor, and there's no causal role of blood pressure. And acknowledgements. Any questions?
Any questions from the audience? At the back.
Possibly. Something we need to look at in more detail. But it would suggest so that could be beneficial.
Fat is an endocrine organ and releases a number of hormones. Do you know if there's a difference between visceral and subcutaneous fat in terms of the endocrine function and how that might affect Dupuytren? Elaboration of estrogens, for example.
So I'm not familiar with the hormonal differences between.
Nor am I.
Great. If there are no other questions, I think we'll move on. Thank you, Max.